Good evening, viewers. Today's topic of presentation is carcinoma gallbladder. Though its topic is more often domain of surgical oncologist, but sometimes the clinical oncologist or radiation oncologist do encounter more often because of a high incidence in the area carcinoma gallbladder. So we should understand the little bit about the carcinoma gallbladder. The gallbladder, so far as anatomy is concerned, is a pear-shaped organ, is 7.5 to almost 12 centimeter long with a normal capacity about 50 ml, but capable of considerable amount of distension of a gallbladder do occur sometimes in the disease. And gallbladder is divided into the fundus, body, and a neck, three parts. And from the gallbladder, the common bile duct which rise after the cystic duct and a union of a common hepatic duct is length is 7.5 centimeter, and this common bile duct is throughout the course. It has a supraduodenal portion. The portion lie behind the duodenum, that is called retroduodenal portion. The below the duodenum, that is infraduodenal portion, and then intraduodenal portion, where it opens obliquely through the wall of second part of duodenum and is surrounded by the sphincter of Oddi. This intraduodenal portion of CBD open as a ampulla, open on an ampulla of Vater or papilla of Vater. The artery supply is basically the cystic artery, a branch of right hepatic artery. We should know the segments of a liver. Whenever we see the CT scan, automatically we should the left portion of the gallbladder on the left side. You see the segments. Predominant segment is second, third, but on the right side you see the predominant segments are 7, 6, 5th, and 4th, and the segment 1 lies behind the liver. So you see here the normal anatomy of a gallbladder, that you see here the common hepatic artery is divided into right and left hepatic artery, and the right hepatic artery give a branch to cystic artery which supply the gallbladder. Also you see the part of a gallbladder here, the fundus portion, corpus and neck, and you see the ampulla of Vater, and then a common hepatic duct and a cystic duct union making the common bile duct. So far as lymphatic vessels of a gallbladder is concerned, the subserosal and submucosal lymphatic plexus drain into the cystic lymph node of Lund, which lies fork-like created a junction by cystic duct and a common hepatic duct. The subserosal lymphatics of gallbladder also connected to subcapsular lymphatic channel of liver. That is the reason why carcinoma gallbladder frequently spread to the liver at the earliest, that is liver infiltration. Usually liver excretes bile at the rate of 40 ml per hour to the gallbladder. So the role of a gallbladder is act more often as a reservoir of a bile, and also do the concentration of a bile, and the hepatic bile is concentrated 5 to 10 times in the gallbladder. You see the nodal areas of a drainage cystic lymph node of Lund. You see here in that picture, and also gallbladder, and the superior pancreatoduodenal lymph node, posterior pancreatoduodenal lymph node, celiac group of lymph nodes, node along the hepatic artery. So the carcinoma gallbladder shows increased incidence with the increase in age, and peak incidence occur around the 6 to 7 decade of a life, and more commonly associated in a female, as percentage varies from 1 is to 2 or 1 is to 5. Geographically, South Indian have a very low incidence of a gallbladder in compared to the north and the central area near the Ganges. At the bank of a Ganges, the cities are located having a high incidence of gallbladder. So what are the etiological factors? The most widely recognized risk factor for gallbladder is a cholelithiasis, and association is almost 70 to 98% for gallbladder associated with a gallstone and a gallbladder cancer. The cumulative risk factor for carcinoma gallbladder for a patient of a gallstone is not enough to justify the prophylactic cholecystectomy for preventing the carcinoma gallbladder. So what happened actually in the GB stone? The stone is lying, it causes a recurrent damage to the gallbladder mucosa and superadded with acute and a chronic inflammation of a GB mucosa and a generation of a carcinogen in the bile by action of the bacteria. That cumulative effect lead to the carcinoma gallbladder. That's a hypothesis is perceived. The porcelain gallbladder is a risk factor for carcinoma gallbladder, almost 12 to 61%, and thus the porcelain gallbladder prophylactic cholecystectomy is justified. In a more often the porcelain gallbladder, you see the palpation of a wall or gallbladder is calcified and thick. A chronic typhoid carriers having a 6 times greater than general person to develop carcinoma gallbladder, and though the ulcerative colitis. Adenomyosis of a gallbladder, mainly in the segmental type adenomyosis, as more commonly associated with the carcinoma gallbladder, almost 6.4%. So far as pathology of gallbladder is concerned, the adenocarcinoma is the commonest histology among the 85%, followed by the squamous cell carcinoma and adenosquamous carcinoma. Among the adenocarcinoma, the tubular variety is the commonest variety. The pattern of spread and a local infiltration lymphatic spread are two common mode of spread. Local and lymphatic is a very common mode. Otherwise, hematogenous, perineural spread, transperitoneal spread, intraductal spread do occur, but the more commonly the local infiltration is lymphatic as well as the local infiltration. A lymphatic drainage of gallbladder starts from the intramural plexus, which is continuous through the all layer of gallbladder wall. The plexus drain into the large serosal lymphatic located along the inferior surface of a gallbladder. So the histological classification you see here, the adenocarcinoma, squamous, adenosquamous, clear cell, undifferentiated, carcinoid tumor, sarcoma, melanoma, lymphoma. These are the variety you see. Among the top is the adenocarcinoma. These lymphatics drain into the pericholedochal lymph node along with the common bile duct, either directly or through the cystic lymph node of Lund. Both these lymph nodes drain into the superior pancreatoduodenal and retropancreatic lymph nodes and ultimately drain into the celiac group of lymph nodes. The retroperitoneal lymph node drain ultimately into para-aortic lymph node. Perineural spread commonly seen in the gallbladder carcinoma, and that makes it very difficult for a gallbladder carcinoma and also for a recurrence of a gallbladder carcinoma. The transperitoneal spread do occur in the late stage of disease and manifest as a omental involvement and peritoneal seedlings and as ultimately culminated into the ascites. So the percentage of lymph node and a percentage of its distribution of a spread, you see the spread lymph node is almost 50.7%, involvement of a liver almost 90%, regional lymph node 70%, perineural spreads 42%, bile duct involvement in 60% and 33% supraclavicular lymph node involvement. The majority of patients present in the stage 3 or stage 4 because do not have any symptoms and usually carcinoma gallbladder is found to have very advanced stage at the presentation. The early carcinoma gallbladder, sometime incidental discovery at the operation of a post-op case of for GB stone, and after the histopathological examination, you found the incidental discovery is having adenocarcinoma. A local adenocarcinoma, carcinoma gallbladder shows the right upper quadrant pain, dyspepsia, anorexia, nausea, vomiting. A jaundice in carcinoma gallbladder is caused by the two factors. One is the tumor infiltration to the bile duct. Tumor itself infiltrates the bile duct or compression of a bile duct. Other is the lymph node around the bile duct, the enlarged lymph node of cystic lymph node that cause the jaundice. The elevation of serum alkaline phosphatase without a jaundice may be due to early compression of CVD or by local infiltration of a liver by tumor or a presence of a liver metastasis. In 80% cases of pre-op diagnosis is now possible by the help of CT scan. Usual finding of a carcinoma gallbladder in ultrasound is the mixed echogenic mass lesion in gallbladder without posterior acoustic shadowing and no postural movement, as well as the infiltration of liver is characterized by the loss of boundary between the liver and the gallbladder. ERCP may be used to evaluate the biliary tree if a USG does not show the extent of biliary obstruction. The histological diagnosis before the surgery can be attempted by the USG guided FNAC from a liver to confirm the diagnosis, or core needle biopsy is contraindicated in view of risk of biliary peritonitis. Staging of a gallbladder carcinoma, you see the T1, the tumor invaded the muscularis mucosa. T2 is tumor invading the perimuscular connective tissue, serosa, and up to serosa. T3, the tumor extend beyond the serosa. T4, tumor extend more than 2 cm into liver or two or more adjacent structure like duodenum, stomach, colon, bile duct, pancreas. So far as the regional lymph node is concerned, the metastasis in cystic lymph node of Lund is N1, N2 is periportal lymph node, celiac lymph node, superior mesenteric lymph node, and M1 is distant metastasis. The staging is very important for as dividing the, for planning the post-adjuvant treatment. Early stage tumor are curable by surgery with good long-term survival. Current surgery is the primary modality of treatment for early carcinoma gallbladder. This is the standard of care. And open cholecystectomy is highly recommended, not lap chole for carcinoma gallbladder. And currently RT and chemo are also used to improve the treatment outcome in these patients. To ensure the prolonged recurrence-free survival, surgical resection should include the potential site of microscopic tumor spread, which are the adjacent liver bed draining the lymph node. Simple cholecystectomy, though it is acceptable in benign gallbladder disease, in carcinoma gallbladder, extended cholecystectomy has to be done. It comprises the in-block removal of gallbladder mucosa, adjacent liver, and portal lymph node. Liver resection carried out with 2 to 5 cm margin and anatomical resection of segment 4 and segment 5, and more extensive liver resection is not required when the direct infiltration of liver by tumor is not present. In carcinoma gallbladder, we resect wedge resection of a liver usually comprises of resection of segment 5 and segment 6, because they are a direct involvement with the gallbladder. And CAGB with liver infiltration, for direct infiltration of a liver, anatomical resection of segment 4, 5 and sometimes segment 6 to be resected out. Infiltration of a tumor in a portal vein or hepatic artery is usually considered to be a criteria of non-resectability of most of the surgeons. A depth of invasion and survival of patients, you see that as per as the depth of other GI tumors, as the depth of invasion is increases, like if it is up to muscle mucosa, up to up to muscle of serosa, or beyond the serosa with lymph node, adjacent organ, so the survival, 5 year survival getting down and down. You see the adjacent organ, 5 year survival in one study by Tashiro et al. Is only 10.9%, and a 156 patient with Agura et al. The adjacent organ involvement, 5 year survival merely limited 7.5%. So these are the that is the depth of invasion and directly inversely proportional to the survival of the patient. The complication of the surgery is usually the anastomotic leak, liver failure, respiratory failure, intra-abdominal bleed. Overall mortality is very low, is 5.3 and a low. Major complication of the surgery is seen when the hepatic resection is there, 48.3%. In an extended cholecystectomy, complication rate is limited to 20% around, and in simple cholecystectomy less than 10% almost. There is no significant difference in the mortality rate in extended versus simple cholecystectomy. So simple surgery for occult carcinoma gallbladder or a carcinoma in situ, like T1A lesion, carcinoma gallbladder, simple cholecystectomy done is sufficient, and a 5 year survival leading up to 60 to 100%. But for a T1B lesion, 5 year survival is 40 to 72%. If simple cholecystectomy carried out of a disease infiltrating the subserosal or serosal layer, results are relatively very poor. To avoid the problem of surprise diagnosis of carcinoma gallbladder, after simple cholecystectomy when gallbladder is specimen sent for the histopathological examination is must. Extended cholecystectomy is the answer when the CAGB incidentally discovered during the gallstone surgery. What are the contraindications to the surgery for carcinoma gallbladder? Multiple liver metastasis, extensive liver infiltration, ascites, multiple peritoneal infiltration, tumor infiltration to portal vein, hepatic artery. When the surgery is not possible, palliative treatment is the choice. The surgical palliation like ERCP stenting to overcome the obstructive jaundice, or surgical intervention in duodenal or colonic obstruction. What is ERCP? Basically, ERCP is endoscopic retrograde cholangiopancreatography is combined with endoscopic and fluoroscopic procedure in which the endoscope is advanced into the second part of the duodenum through by upper GI endoscopy, allows stent to pass into the major duodenal papilla to block if a block is on the lower side, you can achieve the biliary drainage, and then the obstructive jaundice can be relieved. Contrast material may be injected to these ducts, allowing for radiological visualization and therapeutic intervention when indicated. ERCP initially started as a diagnostic procedure, though the cannulation of pancreatic and biliary duct has evolved over the years and currently predominantly used as a therapeutic tool. What are the use of ERCP? Like sphincterectomy, you can do stent placement, stone removal, indication like malignant obstructive jaundice, biliary or pancreatic ductal system disease, and as well as the taking the suspicious of malignancy, taking this tissue for a biopsy. There is another procedure, that is PTBT. The level of obstruction is a proximal. The ERCP with plastic endoprosthesis is preferred. If it is distal, PTBT hair block, the PTBT procedure is there. The external drainage is not required with the ERCP plastic endoprosthesis, but it may required in the PTBT procedure because required in case of unsuccessful internalization of a drainage tube. The percutaneous transhepatic biliary drainage is new but already well recognized non-surgical method of overcoming extrahepatic biliary obstruction. If patient is having advanced malignancy, he can offer a long-term PTBT as a definite palliative treatment. You see here, the doctor is putting the needle for a PTBT with a USG guided assistance. You see the portal vein, biliary radicals, hepatic, hepatic biliary ducts dilatations. So IHBR dilatation, uses the diameter of IHBR dilatation of a duct uh, is giving a clear cut idea where the PTBT is successful or not. Radiotherapy have a very limited role after the surgery, recurrence of disease in liver bed and regional lymph node metastasis, that it makes us logical to consider the RT as a adjuvant treatment after the surgical resection. Post-op RT after the conservative surgery, median dose of 45 grain to 25 fraction provide the median survival of 16 months. Intraoperative radiotherapy also we practice in the carcinoma gallbladder, a single large dose of 20 to 30 gray during the surgery followed by the external beam radiotherapy 30 gray. Palliative RT in non-operable disease, when the malignant ascites is there, you can give pain and palliation, and a malignant ascites 2600 centigrade usually given in fractionated form. Currently, role of adjuvant post-op RT is not well defined, not well recognized as well. So you can see the portal we use for the carcinoma gallbladder. You to do tentative marking. You can go for a CT simulation to identify the gallbladder. The chemotherapy you practice the 5-FU, mitomycin, gemcitabine, cisplatin, all having some results. And a 5-FU is the cheapest one of 500 milligram per meter square, day 1 to day 5, 4 weekly we prescribe. The advantage of this kind of a chemotherapy is a very low cost. Disadvantage is a very low response rate, is almost 18%. The second is a FAM, which earlier days it used to be in a fashion like a 5-FU 600 milligram per meter square, day 1 to day 3, adriamycin 40 milligram per meter square, day 2, mitomycin 10 milligram per meter square, day 1, 3 weekly. Advantage was the high response rate, almost double to the 5-FU, almost 31%, and disadvantage was the high toxicity. The modern chemotherapy agent like gemcitabine 1 gram per meter square, day 1, cisplatin 50 milligram per meter square, day 2, 3 weekly regime. The advantage is there is no toxicity and a high response rate, almost 50%, and disadvantage is a high cost. Incorrect infusion may lead to the significant myelosuppression, like a gemcitabine. If you give a very slow injection, that will lead to the myelosuppression. And there are certain more chemotherapy agents, but let us forget it because of our other colleagues of medical oncologists will do take care of these things. Thank you very much.